by the time it's just coming up, let me have a quick introduction. My name is Vamsi. I'm the Executive Director at Shobha Renaissance Information Technology. We are known as SRIT in the industry. I actually made a presentation which was a topic that was given. But before that, there were 6 scenarios which are given over here. And I also had the opportunity of attending the panel discussion just before the session. So rather than going into details in terms of what my presentation would actually speak, I would like to speak about the ecosystem, the 6 scenarios which is there, and also some of the points which I heard in the discussion just before this. I have a little experience in healthcare. I'm not a doctor. I've been to 100 hospitals in about 30 countries trying to show them what products that I've created over the last 11 years. I've been successful in about 1/3 of those hospitals. Today I have more than 40 hospitals in about 16 countries. Some of them running pretty successfully. Some of them I still get the calls and they pretty much blast me for not having those reports or there are bugs in the software and so on and so forth. Trust me, that's a scenario everywhere in the world. When you go and talk to one of the leading players globally, it's the same scenario still there. Coming to the ecosystem, what is being about creating a seamless healthcare ecosystem. So from my perspective, there's a patient who is the center of that particular ecosystem in the car, and around that you've got hospitals, healthcare associations, labs, device manufacturers, employers, payers, pharmacies, physicians, application providers, regulators, diagnostic centers, and so on and so forth. But where are we really? I mean, because this is pretty much continuing from where what the CIO panel discussion was just before this. Where exactly are we? I mean, as far as India is concerned, I think we're very, very, very far away. Because one, we have no standards on the payer side, which is probably what, if you really look at US, look at parts of Europe, a certain set of standards exist out there because the payers have really pushed them. I'm not saying that they're good or they're bad. I'm saying the payers push them to get those standards. So today we have DRGs. If you go to a certain place in APAC, most of the United States, Europe, you've got DRG out there, so you've got case weights and case mixes. So pretty much you know what is your length of stay. So that was one of the points which just came out in the previous discussion in terms of what's going to be the length of stay. Pretty much what you know what an insurance provider is going to pay depending upon what is the complexity of the case that's actually coming in. So we know that if it's a cardiology, if it's going to be coronary artery bypass graft, and you know that it's a patient, it's an adult, non-hypertensive, non-diabetic, so you have no complexities out there, he's going to be there for about probably 3 days, and that's what the insurance company is going to pay. So those are things which can at least be standardized to a certain extent. Now, then you have various other standards out there. I mean, I can rattle them out in some, starting from ICD-9 to ICD-10 to SNOMED CT to ICNP to NANDA to you have LOINC, you have HCPCS, you have CPT-4, and so many. Probably there are about 65 standards out there as a part of the federal government of the United States, which probably HIS vendors need to look at. There are no standards that we have to follow. We don't have to get a FDA certification or anything as such. But if you really want to create an ecosystem today, whether it is HL7, it is IHE, these are the 2 main standards which exist from a IT standards perspective in terms of exchange of information out there really. But more than that, we have a rural patient out there where there's a health camp being conducted. That health camp could have been conducted by a different organization, but he goes to an eye hospital in a completely different city. So there has been a certain set of tests which have been conducted at that point of time. Probably the guy is suffering from diabetic retinopathy. And that patient goes in over there, and does he have a record? Probably he has a paper record in place, which is coming out at that particular health camp. Now he goes in over there, probably they're going to conduct the same set of tests once again. This could have been just after 3 or 4 days' time, but those tests would be conducted all over again, and then he would probably meet up with a dietitian, and they would also then meet up with an ophthalmologist to actually come out what's to be done at that stage. So there is, in our industry, in our standards, there is a huge amount of duplication which is happening, and this will keep on happening, at least for the next 5 years. I really don't see how we can cut down on the entire amount of duplication. as it was very clearly pointed out, we really wish there are senior government officials sitting over here, because those are the gentlemen who can actually go down and probably create a certain set of committees which will agree upon a certain standards probably in the next 2 years, and so on and so forth. But moving on forward from a vision of connected care, I'm sure some slides before, certain slides that just came up before me. We are looking at physician documentation, looking at smart technologies, stretchers, beds, nursing calls, patient cards, phones, point of care technologies, digital imaging. We're speaking about multitude of facts, whether it is radiology, whether it's cardiology, it's multimodality imaging, PET-CT fusion images coming in, and so on and so forth. Device integration like medical equipment, medications, etc., CPOE, and Pixel systems, which are going to have an automated dispensing machines, and so on and so forth. eHealth, physician-patient portal, self-diagnostic care, physician and collaboration research, disease management, remote monitoring, and so on and so forth. Then you have teaching and research, bioinformatics, biotechnology, ancillary clinicals, telemedicine infrastructure. At this point of time, I just want to deviate for a couple of minutes. I don't have too much of time either way. But there's a small story, and I consider this as a beautiful story. The story is called the Holy Grail. To understand this story, you need to go back close to about 11,000 years back in time. There was supposed to be a civilization, which was 9,000 BC, a civilization where an average lifespan was about 150 years. Every man and woman about 6.5 feet tall. So, considering the height of, probably the height of Dustin Hoffman, so I really like to be the 6.5 feet tall. It was supposed to be a panacea. There was no known disease at that point of time. And for no known reason, they got exterminated from the face of Earth. That civilization was called Atlantis. That has been a holy grail for a lot of cult societies, a very holy grail of archaeology as well. Moving ahead, probably close to about 7,000 years ahead in time, it was the heyday of the Egyptian civilization. They supposedly encapsulated a technology into a book, which is called Al-Munra, and it was made famous by the movies Mummy and Mummy 2. It is called the Book of the Dead. So it supposedly brings back dead people back to life. That's been again a holy grail for a lot of cult societies. Moving ahead into 1500 AD, when the last of the Crusades ended, the so-called Holy Grail, as most of the people knew, whether it's a chalice, whether it is a cup from which Jesus drank during the Last Supper, as per one of the stories that goes in. But that was supposed to give immortality, and that's kind of the Holy Grail which is known to people. Moving on to about 1940 AD, when a gentleman by the name of Alan Turing came up with the Turing's test. That was basically, it's 1950 actually. The Turing's test basically says that there's a computer and a human being in two different rooms, and there's a human being asking questions to both of them. And if they cannot differentiate between the human being and the computer, then the computer passes the Turing test. There's no computer which has passed Turing tests so far, and it's been made famous. The closest that came was IBM Big Blue, which defeated Kasparov in a chess game. But it's been made more famous by Isaac Asimov's novels and the movies, which was Bicentennial Man, and we also had iRobo, Will Smith, and so you have better prosthetics. We could probably go into a small center where we get our hearts get replaced, no angioplasty, just replace the heart, so we don't have to worry about bypasses and so on and so forth. 2005 was called Annus Mirabilis, the Year of Miracles. The last time it was called that was in 1905, when Albert Einstein actually came out with his 5 papers, including the special theory of relativity, and he won the Nobel Prize for the photolithic effect. 2005 was called that because we said that basically RNA is not the core essence as we know, but RNAi, which is ribonucleic acid interference, is the basic element in terms of understanding that. So what it basically means is that I can go down to, at a gene level, I can not only just look at basically it says, putting it very simply, we have zeros and ones in code, we have ACDG as far as genes are concerned, DNA information is concerned. So at the end of the day, I can actually go down and replace a certain information within a particular gene chromosome. I can look at phenomic interactions, how they can actually happen. So it's basically boiling down to a code. I can just go and replace that. So what it means is that theoretically, because of hereditary reasons, I cannot get diabetes mellitus, I cannot get chronic heart diseases, I don't need to get Alzheimer's, I don't not get schizophrenia, and so on and so forth. Is this really true? Well, we're pretty much on the way to that. We have a center, very famous in vitro fertilist, Dr. Collins. That's one of our reference customers in Malaysia. It's called Tropicana Medical Center. That's where we are actually trying out one of these things at a zygote level. How can we change genetic information so that hereditary information is actually removed from that particular zygote? Are we anywhere close to it? No. We're working along with Johnson & Johnson. Also in this, probably in 3 years' time, we would have some idea where we are actually going there. That's one of the reasons why I wanted to speak about, from again, an ecosystem which actually exists. So we'll be speaking about a pharma company, a drug manufacturer, a hospital out there, and an IT vendor. Moving forward, a huge amount of things like measuring performance, standardized treatments, which are absolutely required from a business processes perspective, which will ensure that standards are actually coming into places. So if you see at the bottom of it, we have based on trends and forecasting, so we can have biosurveillance as standards which are actually coming in over there, training, regulation, planning, so we have quality standards which are going to come in, budgeting, optimization, maintenance as financial revenue standards, which will ensure that what between the payers and the providers, what would be the actual value of a particular procedure. DRG coding, regulations, again, part of it are also from a core care perspective in terms of standards, quality of care, public perception, which basically comes out. Third-party interactions, which are absolutely necessary for this ecosystem to work together. So supply chain payment, telemedicine, referrals, outsourcing, electronic health records, and so on and so forth. Going back to the 6 scenarios which were actually given out there, I have cases where we have referenceable customers, where we have a health camp which is being conducted by small or primary care centers, along with conjunction with the tertiary care centers. And this information in an electronic manner actually flows to a secondary care place where these are clinics which exist in the same region. This information goes to them. They actually follow up with the patients out there, probably within 30 days from the time the health camp has actually occurred. And depending upon what's being conducted by these secondary care centers, then we have the patients are actually now separated whether they need to go to a tertiary care center or they don't need to go to a tertiary care center. So this is 6 hospitals and 8 centers in Jordan which are actually doing this, which have been doing this for about 3 years now. And we have a center in Thailand, which is actually, they've got about 40,000 beds with them. It's 16 hospitals, 100 clinics, and 350 specialty clinics, which is there with that particular client of ours. So, has it been fully evolved? No, it has not been fully evolved, but we have certain best practices, and taking that as an advantage, I've already mentioned this to some of the gentlemen who are actually sitting over here. We have gone to the government, we have been working with the government for the last 1.5 years to set up a non-profit organization which is similar to CCHIT in India. We're going to be setting up work groups, committees out there. We already have spoken with the certain hospitals. We have their complete 100% go ahead from them. We've also, and some of these hospitals are also government organizations. So we have both, as of now, private and government participation in this. We have about 8 insurance companies which are going to be a part of this. We also have a lot of large technology players which are a part of this initiative. We will be going down the next one year to various hospitals and other entities to actually provide them what we're trying to do and getting them to be a part of the committee. And our understanding is that for the first year, the committee members will be chosen by some of the key players, and from the next year there will be elections, just exactly as how CCHIT or HL7 actually works. The idea is that we also have members from HL7 who are going to be a part of this. We have spoken to a lot of them. The idea is that at least this entity over a period of 3 years or 4 years would be fully recognized by the government of India.
Mr. Vansi, you have 2 more minutes.
We would be fully going ahead out there, and we would be able to actually come out with standards across all the areas. Right now we're going to be concentrating on administrative areas and revenue areas because that's where we see the major concentration of most of the secondary and primary care centers in India. That's what their concentration is. It's been typically revenue. So if you look at the system, they're more interested in materials management, they're interested in billing and the entire SCM and how that's happening. Can they cut down on pilferage and so on and so forth. Also from a payer's perspective, to ensure that most of the insurance claims go through, so we need to have some kind of standardization that needs to come in. So we will be concentrating on those areas, but definitely there are clinical areas also out there where we're looking at the best practices from an ambulatory electronic health record, or an inpatient electronic health record, or an enterprise electronic health record, and so on and so forth. I've got more details, but really speaking, I want to stop before it. I still remember this thing from the movie Guru, where it says that this is 8 minute ka munafa. So I hope it's going to be profitable for everyone. Thank you so much.